All right, welcome to Grand Rounds, everybody. My name is Venkatesh Aigari, and I'm the Director of Neurocritical Care here at UT Southwestern. And it's my pleasure and honor to introduce today's Grand Round speaker, Professor DaiWai Olson, who's a professor of neurology and neurological surgery here at the UT Southwestern Medical Center, and is also the director of our Neuroscience Nursing Research Center. So Dr. Olson got his bachelor's in nursing from Taco Maycrest University in Davenport in Iowa, and subsequently got his PhD in nursing from the University of North Carolina in Chapel Hill. Dr. Olson started his career as a bedside nurse, worked largely in neurocritical care starting in 1986, and worked in at Duke University prior to him being recruited to UT Southwestern in 2012 when he joined our faculty as associate professor, and subsequently was promoted to full professor in 2018. So Dr. Olson wears multiple hats. He still maintains his interest in bedside nursing, but his other accomplishments are probably more important. He's an educator, a mentor, and a top quality researcher. And just to name a few of his accomplishments, he is the editor-in-chief of the Journal of Neuroscience Nursing. He's held several leadership positions in the Neurocritical Care Society, and he was also awarded the Distinguished Teaching Professorship of the Southwestern Academy of Teachers as a premier educator. He has over 200 peer-reviewed publications and several more non-peer-reviewed publications, book chapters. He's also authored the core curriculum on neuroscience nursing. He's been funded by multiple agencies, and he has mentored numerous physicians and nurses throughout his career. When I asked him what was the accomplishment he was most proud of, DaiWai mentioned that he was proud to be the first and probably the only nurse to be a professor at UT Southwestern. I also thought it would be important to mention some of his interests outside of the field of medicine, since even in our department, we really don't know much about what people do outside of their academic domain. So it might interest you to know that DaiWai was a gymnast of high caliber, so much so that he actually even competed in the Olympic trials, and several of his partners actually made it to the US Olympic team. He is a very keen enthusiast of adventure races and has participated in several of them. And he's also done the low to high hike, which is a hike from the lowest point of the United States in Death Valley to the top of Mount Rainier. Recently, I think just a couple of years ago, together with his brother, he kayaked all the way from Miami to Key West, an 80-plus hour kayaking boat trip. And lastly, together with his wife, Cindy, he owned a dance company, and he was also a choreographer, I believe, of significant repute, and one of the teams trained by him got an award in the Star Search competition, and he's also participated in several country western competitions, partnering it with Cindy. So again, just to end, DaiWai is one of the most humble persons I've ever met, despite his numerous accomplishments. He's always willing to lend a helping hand to anybody, whether it be a bedside nurse, a resident, a fellow, or a faculty member. And his recent interests are investigating pupillometry, especially in neurocritically ill patients, and we're really proud and happy to have him as a member of our division, as well as a faculty member of the Department of Neurology. So take it away, DaiWai.
Thank you for that introduction and reminding me that I did not make the Olympic team. We're going to talk about pupillometry, and I've got a few minutes of your time, and this is going to be a little bit different from some of the grand rounds you're used to. These are my disclosures. Of relevance is Neuroptics, who has provided some funding for infrastructure support. I want to talk a little bit about pupil as a history thing, right? Because for thousands of years, literally thousands of years, we evaluated the pupil as either working or not working. And then about 5-10 years ago, we started to see this new way to look at pupil. And that's what you're seeing in that bottom right-hand corner. And I want to explain this sort of briefly. So your pupil starts out as a certain size. And then light hits the pupil. And for a little bit of time, nothing really happens. But then, at some point in time, if your pupil's working, it starts to get smaller. This is that curve that you're looking at. And after it gets smaller, it recovers back to its normal size. We can express this in a couple of different ways. So we look at this in pupillometry as the initial size. That period from light until initial constriction is called latency. How fast the pupil gets small is called constriction velocity. How fast or slow the pupil gets back to normal is dilation velocity. And all of these things taken together make up something called the neurologic pupil index. And the neurologic pupillary index, including all of these many variables, can be have some defined normative values. All right. Most of you who have heard me speak before know that I love to talk about intracranial pressure. It's kind of like my baby. And so why am I talking about pupillometry? And I am super honored that I was selected to give these grand rounds. But this is where it all ties together for me, is that patients give off cues, and nurses are interested in assessing those. So we're going to talk a little bit about this little diagram you see off to the side. But first I want to explain that the focus of my work has been and remains that I strongly believe nursing care makes a difference in outcomes. So far, nobody's disagreed with me. There's a barrier to that. And that barrier is something we're going to cover with little statistics. Now, residents, I hope you're paying attention. There's a test at the end, but we're going to go into statistics. And normally you see this particular type of formula. And when you see this formula, some of you immediately go into your shell. You get a little PTSD. But this is expressed fairly easy. I can read this formula as the outcome is predicted by where you started, plus the influence of a bunch of variables, plus some component of error. Again, the outcome is predicted by where we started, plus the influence of a bunch of different variables, plus an error term. In this case, I've color-coded these. Look at it again. Outcome predicted by where you started, plus a bunch of variables, plus error. I'm going to give a quick example with neurology. We've seen this before. 90-day modified Rankin score is predicted by how well the patient was before they had a stroke, plus their NIH, their age, did they get alteplase, are they male or female, and then a whole bunch of other variables that we typically don't measure, and then an error term. Putting this back in our formula, same color coding for you, we can say discharge modified Rankin, this is our regression formula, is predicted by baseline plus these variables and some that we don't know about plus error. Okay, so far you should be with me. Here's where it gets to be a little bit upsetting to me. The other stuff that we didn't measure, that's what I do for a living. Typically that other stuff is nursing care. That's one of the big other stuffs, right? When we see a stroke patient, you'll have the stroke physicians, and you guys are brilliant. brilliant. Walk in at 9 a.m. and you say, oh, this patient has gram-positive cocci that's sensitive to vancomycin. And at 9:15, you put them on vancomycin, and then for the next 23 hours and 45 minutes, they receive nursing care. But what we're looking at typically is what happened in those 15 minutes. What did the physician order? So I think nursing is important, but I think it's somewhat neglected. Now, this takes me back to my primary argument about nursing making a difference. And I'm going to explain this a little bit different. We're still in our regression. Let's pretend you have some event that happens. After that event, there's a lot of different variables. And there's some intervention. So our variables maybe are like NIHSS, age, sex, et cetera, et cetera. Our intervention is all to place. And then there's nursing care, and there's other confounders and things like that. And we can express these univariately as a little r, as r squared. So for instance, our intervention in this hypothetical example explains 30% of the outcome, right? It's 30% of the variance in the outcome. And if you add up all of the known variables and their influence in this pretend example, we can explain 70% of the variance in outcome based on what we know. Notice that nursing is just that question mark. We don't know what that is. Well, there's lots of things besides nursing we didn't measure. And we could have. We could measure very precisely how long the patient's fingernails are. But we didn't, because we don't think that makes a difference in the outcome, right? We don't think the length of their fingernails is very important. We can measure whether or not the patient was born on a Saturday, but we don't measure that because we didn't think it was important. There's lots and lots of stuff we could measure, but we have given the choice, the decision not to measure these. Basically, we only measure the things we think are important. And the fact that we don't measure nursing kind of pisses me off, because that's sort of like saying we don't think it's important. I think the real reason is we're not really sure how to measure it yet. And that's a little bit of what we're going to talk about. Theory is an important element in how we get to what we're going to do. How are we going to design our experiments? So prior to Hippocrates, there was this belief that all disease was caused by gods. And Hippocrates, he was one smart fellow. He goes, yeah, it's not by the gods. It happens naturally. And he said there's 4 things that cause all diseases: blood, yellow bile, black bile, and phlegm. And so for several hundreds of years, we tested the 4 humors theory of blood, bile, black bile, and phlegm. And it turns out it was a good idea, but it was wrong. So theory becomes important, and theory is not just an idea. It's not like a random ass idea of guess, I think maybe this is going on, but theory is actually a defined argument. It's peer-reviewed, it's shared, it's written. Oddly enough, over the last 100 years, medicine has kind of moved a little bit away from being a theory-based science and having these theory-based research and interventions. And nursing has become more and more theory-based, especially after World War II, where we saw a big advance in nursing. In nursing school, I hated theory class, and I thought theory was really stupid. And then I became a nurse theorist, and now, oddly enough, I think theory is a good thing. So this is my theory. This is called the Q response theory, and Stephanie Ortega has published with me, as well as Carmela Graffinino back when I was at Duke, and Suzanne Thori. We're not going to go over the whole thing, but in a nutshell, what happens is there's some event that happens to our patient. That event causes a brain injury. They get hit with a baseball bat. That brain injury results in impaired function. Now, that impaired function provides cues that nurses can assess, and then nurses can decide from the many interventions they have, they can decide when to do the intervention. And this is the thing I think is really important. If I do the intervention at the right time, then the patient moves to the right side of your screen, moves towards recovery. If I do the intervention at the wrong time, they move away from recovery towards more impaired function or even secondary brain injury where things get worse and worse. The central part of this is what's really important and why I'm interested in pupillometry. Nurses assess cues. Now, cues can come in lots of different forms. If the patient's heart rate goes from 100 to 0, well, that's a cue, right? That's a pretty blatant cue. But what if the patient's just a little bit more fidgety? As nurses, we look at this, right? Well, they were fidgety. Now they're even worse, right? What if they're sweaty, just a little more sweaty than they were? What if they were fidgety, but now they're just like really blasé? These are more subtle cues that I think are important that help tell us about the timing of events. And I'm going to give 2 examples how this works. And for key reasons, I'm purposely using very, very diverse example. Here's the first example. This is where nursing care results in a bad outcome. And the reason I think it's important that we understand that I can clearly demonstrate that nursing care can cause a bad outcome, because if nursing care can cause a bad outcome, then nursing care can also cause a good outcome. Here's our patient. They have an intracranial pressure of 32. The nurse walks into the room, there's poo everywhere. Oh my gosh. My intervention is, I've got to clean this patient. I'm going to clean their poo. I'm going to lower their head of bed. I'm going to clean them up, roll them side to side, put on some new linens. And then when I look at the ICP again, it's gone from 32 to 70. My patient's herniated. They've got secondary brain injury, and the next day they're dead. This is a bad outcome. Death is not a good outcome. Okay, same patient, but now I'm going to demonstrate how nursing care can make an improvement. I walk in, my ICP is 32. I look at my patient, yeah, they had a big poo, but look at that ICP. That ICP is 32. I know I got to clean them, but I got some other stuff first. I'm gonna time that poo cleaning session till later. I'm going to raise the patient's head of the bed. I'm going to call Dr. Iagari. He's going to give me some mannitol orders. I'm going to give the patient mannitol. I'm going to watch that ICP come down. And that ICP comes down. Once it's stable again, then I'm going to clean my patient. And I'm helping move that patient on a trajectory towards recovery. So this is how the cue response theory plays out. It's all about nursing assessment and cues. The reason I'm interested in pupillometry is because I'm really interested in cues. Cues are an assessment component of the nurse, and that helps the nurse, that helps us determine when an intervention should occur. For those of you who are physicians or therapists, the reason you should be interested in pupillometry is that if I assess a patient poorly, I'm going to give you bad data. If the nurse gives you bad data, it's hard for you to make good decisions. If I give you good data, it's easier for you to make a good decision. This is a particular cue. So I think this is where nurses, physicians, everybody, we're all in this together. This is, I promise this is my only, I think this is my only physiology slide. It's going to just be a 30,000-foot view of the pupillary light reflex pathway for those of you to get everybody on board. So here's what happens is light hits the eye. When light hits the eye, an electrical pathway travels along the second cranial nerve back to the Edinger-Westphal nucleus. That sends a signal along both third cranial nerves, and then that causes both pupils to constrict. This is in a normal, healthy patient. This is how it should work. And we've represented this from a slide about 7 or 8 slides ago as to what we see as the pupillary light reflex curve, and we can measure different parts of that. Hypothetically, We're at UT Southwestern. We're in a brand new ICU. I did mention before, for those of you who joined late, if you can type into the chat, I'm just very curious to see where everybody's from. So in Dallas, UT Southwestern, Donald Brain Institute just opened up a brand new neuro ICU on Monday, and we're going to do this hypothetical. You are an advanced practice provider or a physician taking care of the patient in room 392, and I'm the nurse. And at 2:05 a.m., I call you and I say, patient is not doing well. We got problems. I go through my assessment, and part of my assessment is the pupils are equal, round, and brisk at 3 millimeters. If I give you that information at 2:05 a.m., do you have any idea how well or how poorly their pupillary light reflex pathway is working? The answer for several thousand years was yes, but it turns out we were wrong. And I'm going to demonstrate a little bit of that in about 5 slides, but first I want to go over a couple things. The way I got into this is pupillometry had sort of been out and about a little, and we came up with a pretty simple question, I think, is how good are humans at looking at pupils? As a nurse, I've looked at a lot of pupils in my lifetime, shine flashlights, and we've all kind of had that thing where, what do you think? What do you think? And you call your friend in, you go, do you think that's brisk? Do you think that's sluggish? Is that working? Is that not working? And so we decided to blind our clinicians. We had doctors, we had nurses, we had advanced practice providers, we had everybody. And we looked at almost 5,000 eyes. Huge number. I'm not going to go over the entire paper, but I hope you read it. And I am going to show you table 2. If we look at percent agreement, in other words, what percent of the time do we agree on the pupil? On the size of the pupil, how big the pupil is, we agree about 78% of the time. Not bad, lower than I expected, but not bad. On the shape, round or not round, we agree about 95% of the time. I thought it'd be 100, but even that, 95 is not bad. And on the reactivity, we agree about 80% of the time. And this is across the board. 80% isn't great. That means 4 out of 5 times we don't agree whether or not it's reactive. But here's the issue. This is not the correct statistic to interpret these data. We're going to talk about Cohen's kappa. Cohen's kappa is useful because if you were to make a guess, I tell you I got a patient down the hall in room 8, and I said, how big do you think their pupils are? You would make your best possible guess, and your best possible guess would probably be about 4 millimeters. Some of you might say 3, 3.5, whatever. And I said, do you think they're round or not round? And if you had to make a random guess, you would say, I bet they're round, right? I mean, if you're putting money on the table, you're going to bet round. Do you think they work or don't work? You're going to say, well, if I hazard a guess, I got no other information, I'm going to guess that they work. And that's the problem. For the majority of the population on the planet Earth, our pupils are round. For the majority of the population on the planet Earth, our pupils are about 4 millimeters. Turns out 3.5. And for the majority of the population on the planet Earth, our pupils work. So just guessing is a problem, and kappa statistic is useful to evaluate agreement when one option is less likely. And the option that's less likely is that they're fixed or that they're an abnormal size. This is data from the paper I just mentioned to you, and we're going to dichotomize, right? Is the pupil working or not working? Is it reactive or is it fixed? And I ask observer number 1, what do you think? Pupil work, yes or no? And I ask observer number 2, after number 1's done, and they don't get to talk to each other, is the pupil working, yes or no? From 2,324 samples, 2,135 times, They both said, yes, the pupil's working, and they agreed upon that. And 94 times they both agreed it was fixed. But look at those other two boxes. 47 times, observer number one said it's fixed. This is a pupil that doesn't work. And the other one said, nope, it works. And 48 times, the observer number one says reactive, and observer number two says, no, that's fixed. That's a fixed pupil. Now, the difference between a fixed pupil and a reactive pupil can often be the difference between, let's bolus this patient with mannitol. Let's drill a hole in their head and suck out their brain juice. Let's do something for this patient emergently. So getting it right is fairly important. If we looked at simple agreement, we would see that we agree 96% of the time, but I've told you agreement is not the correct statistic, it's Cohen's kappa. We're going to go over this, but I'm not going to torture it with you or torture you with it. Essentially, kappa is what is the probability of agreement minus the probability of random agreement divided by 1 over the probability of random agreement. We did that math for you, and we're just going to look, there's kappas for all of these, but we're going to look at them for both eyes, and this is where the rubber hits the road. Our kappa statistic, a good kappa statistic is at least 0.6, 0.8, somewhere. You want a higher statistic that goes from 0 to 1. Just on the size, our kappa is 0.5. Not great. But some of you would say, size isn't important. Shape, 0.7. Again, I mean, almost everybody's round. I would just hazard a round guess. We were talking about this yesterday, Dr. Owen and I. And so the kappa statistic for whether or not we agree on shape is marginal. But look at whether or not we agree that the pupil is reactive. 0.4. That is abysmal. That is a really low kappa statistic. But it resonates with everything I've seen in 35 plus years of clinical practice. The number of times I'm shining that light again and again, and is it fixed? Is it reactive? I think I saw a little bit of movement, right? So the truth is, as humans, we're just not very good at this. We're not good at evaluating pupils. In fact, we're bad at it. We're not good at all. But that was in the intensive care unit. Now, again, this is in the neuro-intensive care unit. My physicians who participated were neurosurgeons and neurologists. My nurses were neurocritical care nurses. I mean, we had people who look at pupils for a living frequently. I had advanced practice providers who did this day in and day out. And then Lillian Umbro said, well, yeah, but what about in other places? What about in PACU? What about in post-anesthesia care? And she looked at how good are we at looking at pupils in PACU, and it turns out we're not good at looking at them in PACU either. They're just as bad as we are. So here's where we stand right now. We found out that the inter-rater reliability study, which was a very simple question, but used the correct statistic, said we don't agree as humans on how we evaluate the pupillary light reflex. We're not good at it. We don't agree. And everyone I've talked to, when I talk to my physicians, they're like, yeah, we're still pretty convinced that you should check the pupils. I'm like, okay, so you want us to check the pupils, but humans checking the pupils is just a waste of time. So what do we do? And then this is where pupillometry comes in. What you're seeing on the right-hand side of the screen, this is Danelle, and Danelle is checking pupils here. And you can see this is a pupillometer. One of the cool things is, even in this video, you can see that pupil getting small. One, we just magnified it. Now, this is a person who has brown eyes, and 80% of the world's population has brown or dark brown eyes. Now, you take a patient with dark skin, a dark brown eye, and a 2-millimeter pupil, and you go into their room at 3 a.m. and tell me you can tell the millimeters per second at which that pupil is constricting, I'm calling you out. I don't think you can, and we've got the data to back it up. So we found that automated infrared pupillometry, or pupillometry, has potential, but we don't really know yet, right? This is about 4 or 5 years ago. We're really not quite sure, right? But it makes sense. When we first started looking at temperature hundreds and hundreds of years ago, we were trained. We felt the forehead. You felt the chest. Is this patient hot or not? Do they have a fever or not? And then we invented a temperatureometer, a thermometer. When I started as a nurse, we would feel for a thready pulse or a bounding pulse. And we pretended like, oh yeah, they've got a bounding pulse. That's at least 120, right? And it turns out we sucked at that too. So we use meters for the blood pressure, manometers. Oxygen saturation, before that was invented, we always squeezed their little fingers, and we looked at cap refill in 1, 2, 3 seconds, and most of us would count to 3. But even that was inaccurate. Can you imagine today in COVID trying to discern the difference between a patient with an O2 sat of 91 and an O2 sat of 89 without an oxygen saturation meter, a pulse oximetry, right? Going, well, that was 2.8 second cap refill. I know what's going on there, right? So the idea to measure a pupil, to meter the pupil, isn't really a big stretch. Pupillometer is nothing fancy. It's nothing more than a meter for the pupil. Well, before we went ahead any further, Dr. Iagari, shown here in his standard ICU form, said, we got to make sure that 2 machines are going to give us the same answer. I mean, what good is it, right? What good is it? We know 2 humans don't get the same answer, but do we know that 2 machines will get the same answer, right? If I weigh you on this scale, and I get that your weight is 120 kilos, and I weigh you on this scale, and it says 60 kilos, well, obviously only the one that's 60 kilos is correct. We're going to take the number we want. They're not equal. So we did an inter-device reliability study of the pupillometer, and lo and behold, pretty much as we predicted, we have this whopping kappa statistic that approaches 1.0. So if I use this pupillometer and bring in a whole different pupillometer, I'm going to get the same value. And most of our kappa was size and stuff like that. So that's pretty good. Here's where we sit now. Humans, not reliable. Machines, reliable. But where does that leave us? Right? We need more data. We know the machine's reliable, but do we care? Does it matter? If I could reliably measure how fast the hair on your arm grows, I could precisely measure how fast does the hair on your arm grow, hopefully you wouldn't care. It certainly doesn't seem to be a predictor of outcome. But does it matter if we look at the pupils more accurately? So in order to begin to address that, we started something called the Establishing Normative Data for Pupillometry Assessments in Neurointensive Care, the IND-PANIC study. We currently have 4 states, California, Texas, Ohio, and Pennsylvania, and we have sites in Germany and sites in Japan that are contributing data, and we are super excited. We have, we're approaching 6,000 patients and about 1 million data points. So we are definitely moving forward in what questions we can ask. But Dr. Lucere came up with a great question. If I walk up to Bethany and say, hi, Dr. Lucere, my patient's pupils they have an NPI of 4.1. What does that mean to her? This is a brand new value, right? 10 years ago, most of you, probably none of you, had ever heard of an NPI. If I tell her the latency, the period of time between when the light turns on and the pupil starts to change size is 0.2, should she be concerned? So, pretty simple study. We looked at a big ton of our data, and we said in the neurointensive care unit, in patients who are sick, these are not healthy individuals, in patients who are in the neuro ICU, what would you expect for the most part? Also, because we knew we were going to do more studies and we're going to want to power those studies, we need to know the rest of that data, their mean, their standard deviation, their median, and the interquartile range. So if I were to randomly guess now, I would guess that the pupil is going to be 4.2 for an NPI, 3.5 millimeters in size. It's going to take 0.3 seconds from when the light turns on until the pupil starts to constrict. That pupil is going to constrict at a velocity of 1.6 millimeters per second, and it's going to dilate. It's going to recover at a rate of 0.7 millimeters per second. This was super helpful because we can reference this paper without going in doing this every time. We can reference the paper. Here's where we sit now. Machines are reliable. Humans are not reliable. We have a bunch of data. We have a machine. But again, I still haven't answered that big so what question. I call Dr. Figueroa at 2 a.m. I give him the NPI, the size, the constriction velocity, the latency, the dilation velocity, and he says, yeah. And you're calling me at 2 a.m. because, right? We still don't know if it's important. And then I'm going to talk about Dr. Shoyambo's paper, but first I'm going to give you a little chance to play along. You're going to evaluate the pupillary light reflex. And you can call it brisk, you can call it sluggish, you can call it fixed. And this is kind of hard to look at, so I'm going to make this even easier. And here's my first pupil, okay? There's your pupil. Light hits it. What would you call it? What would you call it? Let's do another one. Here's my pupil. Light hits it. What would you call it? Well, I actually cheated a little bit, and I designed this a specific way. That first pupil was 4 millimeters in size. After the light hit it, it shrunk down to 2 millimeters in size, and it did that over the period of 1 second. So I'm going to call that 2 millimeters per second. That second pupil started out at 9 millimeters in size. It shrunk down only to 8 millimeters in size, but it shrunk in a half a second. So that's 2 millimeters per second. Both of these pupils were brisk. Both of these pupils were fast pupils. But now I'm going to ask a question a little bit different. I'm going to ask you if you think this pupil works normally or abnormally. Is this a normal pupil or an abnormal pupil? Here's our first one. And hopefully you would say, I think that's normal. Light hit it, shrunk down, got small, right? Here's our second one. Big old pupil. Light hits it, and hopefully you would call that abnormal. Like if I saw that in a clinical setting, I go, well, that's kind of odd. It didn't get all the way smaller. It just kind of stopped right there. And the analogy that I use for this is imagine that you've got this drag strip. There's two cars, two high-powered cars, right? And that light goes all the way down to green, and boom, they hit the gas, and both those cars get up to 180 miles per hour. That's fast. They both got really fast. They're both brisk. But halfway down the track, one of those cars bursts into flame, flies into the air, and never makes it to the end. Hopefully, most of you would look at the car that got up to 180 and made it all the way to the end and the chute deployed, and you say, that's a normal dragster. And the one that flew up in the air and burst into flames, you go, there's something odd about that. That doesn't seem to work normally. What if the light goes green and that first car takes off at a bolt right away? And that other car, right, you can hear it going, motors running, but it ain't moving. And then after about 5 or 6 seconds, all of a sudden, then it takes off. That's a delay. That would be a latency delay. We can look at all kinds of different parts of the pupil. And this came about because neurosurgery called me down to chew me out for a patient that had a abnormal neurologic pupillary index, but the pupil was brisk. And so Dr. Shoyombo started looking at this, and I think I get to present his data in about 3 slides. And we started thinking, all right, humans are not reliable. Machines are reliable. We have a lot of data. It seems like it might make a difference, like knowing that the pupil, right, having the ability to look at an NPI instead of just is it fast or not is going to be important. So should we trend it? Should we report it? Should we share it, right? And then we had, this is Dr. Al-Abaidi, and he looked at an earlier publication by Molly McNett, where she had looked at increased intracranial pressure. And we said, well, we've got a bunch of data. Would we get the same answer? If you're wondering, residents, can you publish a replicative study? We followed her methods to the T. We did the exact same thing, and we got the exact same answer. This is good. This is robustness. Then we started a couple of other things. This is Dr. Alun, who started, I love this story. When pupillometry first came to UT Southwestern, there was no one on the planet who hated pupillometry more than Dr. Alun. He was set on getting rid of these things. Man, are they stupid. And he set about to prove how bad they were. And in the process of proving how useless they were, he discovered, man, these things are pretty good. This is important data. And he found that changes in the NPI correlated with delayed cerebral ischemia. We looked at TCD and NPI and found they weren't coupled. They weren't correlated. But then digging deeper, it looks like the NPI change precedes DCI change. So this is starting to get us interested, right? Now these might be an early warning. Dr. Ortega-Perez also looked at subarachnoid hemorrhage, and she looked at it as a predictor of outcome. And she found that higher within subject standard deviation, in other words, if my pupil goes not working, working, not working, working, not working, working, not working, working, right, that the NPI is going up and down, right, that's not good. That portends a poor outcome. So that told us we should really be trending the neurologic pupillary index. Dr. Osman looked at NPI values correlated with septum pellucidum shift. Dr. Igari made him measure hundreds and hundreds of shift on CT scans, and it turns out that a drop in the NPI value might be important because the greater the shift, the lower the NPI. This fits the physiology that we've always hypothesized, that shift. Now, we don't know yet how early these changes happen, but we're starting to see this signal. We've looked at, again, after Dr. Un got the bug, now he's hit for this shift here. The NPI also correlates with impaired cranial nerve 3 function. Makes sense, right? We're testing physiology now, but what we found surprising is that an NPI change can occur up to 12 hours before you see clinical symptom changes. In other words, by following and trending this NPI, and we're not quite sure yet where to draw the line, right? But by following this NPI, we can see changes. Wouldn't it be great to have 12 hours advance notice? I got to do something. I could intervene now and prevent this other thing from happening. Then we had some silly questions. I told you earlier, 80% of the people have dark brown eyes. Someone asked us, yeah, well, the pupillometer is it's going to work differently if they have blue eyes or whatever. So we got, for about 3 years, we looked at every patient's eye color and we put that in a nice statistical program. And it turns out pupillometer doesn't care what color your eye is. It can be brown, it can be dark brown, it can be green, it can be blue, it can be light blue. I also found out there's something like 57 different eye colors. Which was astounding, but pupillometer is agnostic to eye color, which was nice. That means that the nurse doesn't have to document eye color. Whew. Good thing. We're documenting way too much stuff now. Dr. Iagari also mentored Satoru Wira-Kun, and this is kind of fun because, you know, we've hypothesized Horner syndrome, and if you see that carotid plexus stretching, you're thinking sympathetic, parasympathetic, and how does all this work? And it turns out that carotid stenting does seem to be associated with PLR changes that we've seen in Horner syndrome. This is nice because it provided convergent validity that pupillometry, not only does it do this cool thing where it measures the pupil with this fancy camera, but it fits the pathophysiology that we've suspected, right? So this is convergent validity. Dr. Alamedia has what I think is going to be one of the most groundbreaking trials of 2020, beyond all the COVID stuff. He looked at patients who came into the Parkland ED. And one of the things most of you know is if your patient has a GCS score of 8, if my mom comes into the hospital and car crash and her GCS is 8, they're going to do surgery. Somebody's going to drill a hole in her head and suck out her brain juice or take her to the OR, but it's indicated. That's in the guidelines. If you're following the guidelines, you got to do it. But what if the patient's just drunk? What if there's something else that's causing that GCS of 8? The cool thing we found with this is if the patient has an NPI greater than 3, which is considered normal, regardless of what the GCS was, they didn't need surgery. We didn't need to drill a hole in their head. We didn't need a ventriculostomy. We saved that patient a lot of problems. As a side, we looked at the patients with GCS of 14 and 15, and we found that their pupil dilation was abnormal. So not in all of our 14, 15s, but only in the patients who said they had loss of consciousness at the scene. So this is like concussion. Now we're talking with folks who are much smarter about concussion, like Monroe Cullum, and we're starting to look at, does pupil dilation associate with concussion? Can we start putting this on the field? And what can we do there? And we're looking at an NIH grant we're going to be submitting for that. I'm not going to go through every paper, although I'd love to if you want to come up to my office sometime. We published our registry. We published methods for cleaning, the methods paper. We've talked about pupillometry and the changes and put out a couple systems review. Most recently, and by recently I mean like really recently, Barsha Thacker, Hind, Dr. Atim, published dilation velocity and patient recovery times, where we found that abnormal dilation velocity affects recovery times and brain injury. And then Khadija Mazar, who's going to be one of the best neurologists ever, found that supratentorial ICH, along with other variables in a multivariate prediction model, helps predict the NPI. In other words, these things are associated. Again, we're finding robust data to support the physiology we've thought. So it's fitting. This is convergent validity. This sums up as, we know humans aren't reliable. Not only do we know they're not reliable, even if I could reliably tell you that the pupil is brisk or sluggish, the Shoyambo paper showed me that if I call you at 3 a.m. and say the pupil's brisk, I have not given you enough information, because if it briskly goes from 9 millimeters to 8 millimeters, it still ain't working right. So I need to give you more information. Pupillometers are objective. They work the same way again and again. We have this big database that has lots of wonderful data. Any of the residents that want to publish, we've got stuff for you. NPI is robust to subarachnoid hemorrhage, ICP, ischemic stroke, ICH, TBI, all of the bread and butter stuff we see in the neurocritical care. The physiology is backed up by what we see and what we expect in regards to midline shift, cerebral edema. We've seen the sympathetic response. It looks like, at least for now, it precedes a clinical change, so it's an early warning biomarker. And there's lots of other indices that may be associated in consciousness. We haven't looked at dilation velocity very well yet. We haven't looked at latency at all. Like, what happens with that conduction delay? So we're getting more and more questions. The thing that's no longer a question is, we no longer wonder, at least I don't, I have no doubt in my mind that 5-10 years from now, nurses will not use flashlights. It's a complete waste of time. Even if I could use it correctly, I'm not going to give you the information you want. So it's no longer a question of whether or not we're going to use flashlights. We have all new questions. And that's kind of the exciting point in science. How often do I need to assess? Is it every 5 minutes? Once every 4 hours? Once a day? Only on admission, right? Should I assess every patient's PLR? If you as a physician want me as a nurse to assess the pupils, I'm going to be using pupillometry, because we know flashlights don't work, right? How often, and should it be every patient, right? What about non-neuro nurses? You get called all the time. We get called as a consult to cardiology, right? To MICU, to SICU. We get called down everywhere. You see police holding flashlights, checking patients or checking people on the street and saying, "Oh, I'm taking you to jail because me as a policeman standing here in Fargo, North Dakota in negative 10-degree weather has decided that your pupils are abnormal." What about latency? That time from the light going on until constriction started. Is there a threshold point at which point you as a physician want me as the nurse to call you? If there is, what is that? What about anisocoria? Dr. Owen has a paper under review right now on anisocoria. What about how can we make a difference? If I raise the head, if the ICP is going up and I raise the head of the bed, did I shift the PLR? And if I did, what does that mean? Is that a good thing, a bad thing? Feels like it would be a good thing, right? But we've got to look at this. What's the association between GCS and space-occupying lesions and PLR? Like if I got a tumor that grows really slow, does it change, right? If it's pushing up against that third cranial nerve, am I going to see that, right? What about just edema? What about all of the medications? We get called all the time. This patient's, we turned the sedation off yesterday, but they're not really moving around. Will pupillometer give us clues as to sedation? Or maybe analgesia needs, right? You got a parasympathetic response going. Alcohol, THC, right? We have no way right now to test impaired drivers, no objective way. How does pupil work in some of these weird things like detached retina? The folks in Europe and up in Maine have started looking at pupillometry as a predictor after cardiac arrest, and they've found robust data. There's nothing but questions. I have tons and tons of questions, but I'm going to stop here because I'm hoping that that you have some questions, and so that's where I'm going to stop for now.
Thank you for a wonderful talk, DaiWai, and for reaffirming that the neurological examination still matters, and that there are still many unanswered questions about things that we do in day-to-day practice, and whether we're on the right track or the wrong track, and also for demystifying some of the math that's involved in terms of answering some of these questions. So that's not a question, but just more of a appreciative thought.
Thank you. I'm going to try to go through some of these questions I see too. Any medication that can affect pupillary light reflex. We've got the data, Theodora, but I don't have anyone right now to ask it. We have so many other questions, but hit me up. We'd love you to join us and help us answer this question. Has anyone looked at this in correlation with dementia? No. What a fascinating idea. I did see that there's an early paper on about Alzheimer. Oh, Dr. Iagari is answering that one. There's a paper I saw reviewing for this talk yesterday about Alzheimer and the PLR, but I didn't get further. And then Scott Elrod, has anyone looked at MPI with migraine? Not that I know of. If if Deb's on, she might know. But that's these are such great questions. Is it affected by sedation? There's only one paper that I know of that's talked at all about sedation. We don't really know that it's affected by sedation. It appears to be not, but there's so many different sedatives. Thanks, Monroe. Also curious about other conditions that might affect dehydration. You know, dehydration and exercise that confound the concussion result. We did have a bit of a talk about dehydration, more along the lines of hypotension, but I can see where that would hit up. Ardra asked, can you assess pupils in coma patients? Yeah, absolutely. You hold their eyeball open, and that patient, if the patient has a pupil, you can assess it. Is that Sheila Alexander from Pitt? Hey, is there a value in using? Yeah, so we've started using pupillometry in the ICU or the ED at Parkland. They have one in the ED at Clements. We're seeing them in PACU. We're seeing them in pre-op. Our step-down floor has it. Our stroke unit floor has. Our post-neurosurgical floor has. I think our MICU and SICU both have them. I'm not sure how often they're being used. Sheila, it's my opinion that if you're going to look at a pupil,
Oh, it looks like, DaiWai, if you can hear us, it looks like you froze up.
Oh, can you hear me?
I can now, so we didn't hear your answer.
Damn, and it was really good.
I'm sure it was.
Oh, it was the best answer to any question ever. So the answer was, the question was, are they using pupillometry outside of ICU? And the answer, short version, is yes. We're using it at UT Southwestern. We're using it in the emergency department, the recovery room, the pre-anesthesia. We're using it for our stroke patients on the floor, for our neurosurgical patients on the floor. I believe MICU and SICU both have pupillometry. I'm just not sure how often. Missy Moreta, hi from North Carolina. Wonder if uncontrolled diabetes. Okay, so yeah, thanks for calling me out on that. I was reading up yesterday. There was this one hint about hyperglycemia and hypoglycemia, mostly from the motor component, and I didn't get to address that. Dr. Iagari, if you're on and you have a better answer about diabetes and pupillary light reflex, I'd love to hear it. Rana Syed is using it at ICU at Children's, yay. How much resistance? So this is from the UK. My big resistance was Salah Aoun. Dr. Aoun, if you're on, you could poke in. And I loved it. I love the fact that he was a major skeptic. And once you start to use it and you start to see how it works, a lot of that resistance starts to fall away. The question you have to ask is, do you care about whether or not the pupil works and how well it works? If you care about it, there's no data that I can find that says that a human can tell you how well the pupil works. We're not very good at it. We don't even agree on when it's fixed. So in terms of that, in the UK, I would hope, you want to know it works, then you should ought to measure it. And this is the way to measure it. Yeah, we're using them on the regular floor as well. Could it be too sensitive? Sometimes I get calls about low NPIs, but then bad things don't ensue. Yeah, so I don't know who wrote this. It could be too sensitive, or it could be that we don't know how to tell when it's too sensitive. I remember back in 1980 when I was starting in the ICU over 30 years ago, patients would go into VTAC, and then we discovered they weren't in VTAC, they were brushing their teeth. And now that's pretty common, right? So the EKG was overly sensitive to what really wasn't dysrhythmia, right? And so it's quite reasonable to expect that there's an NPI change where we should or shouldn't contact the physician. And your example of, you don't care if the blood pressure goes from 128 to 125. I don't know who wrote this, but I love you because I use that example all the time. Does it matter if the NPI goes from 3.2 to 3.1, from 3.0 to 2.9? These are good questions that can be answered with data. So I agree with that. I can stay on and I'll answer a couple of these, but I know that we are past the hour, so I do want to thank everybody. I think I got to go one slide here, and that everybody should be able to see how to get your CME if you're in the system there. Pepper, can I keep going or?
Sure, yeah, this session's being recorded and I'll stay on here with DaiWai to get the questions answered. If you miss a question, you're more than welcome to check the recording online.
Okay. Chris Conrad hated it and now loves it. Yeah. Dr. Vernino, thank you for the reference. Can you email that to me pretty please? I know that we had looked at it before, and there's a couple of folks from Duke or from UT Southwestern that had looked at pupillometry years ago. Dr. Stuve had looked at it. Salah agrees with the potential applications. Melanie Trong. Okay, thank you. Diabetes can cause ciliary ganglion dysfunction, which causes the tonic pupil that may affect NPI. Oh, thank you for jumping in with that. That's a whole nother study we could do then. Dr. Mahoney, 1980, what? 1983, thank you. Thank you for the compliment. Pupillometry in mice is hard, but Dr. Stuve did it. He's our guru. Oh, Stuve and Vernino. I'm sorry, Dr. Vernino. Yeah, you guys have a paper that we've reviewed that's amazing and had a little headset, so I'd love to do more with that. I think I got all the questions, Pepper.
Did you get the one from, I might not have just heard it, but from Peter Tomlinson? How much resistance have you received here in the UK?
Yeah, oh, I did. Maybe I cut out on that. So the resistance that I received originally was from neurosurgery, but now, and that was from people like Dr. Olson, but in testing it, they found it's robust and it actually works. So like most things, non-political, the more evidence you provide, the more likely you are to convince other people of your position. And you have to be open to the fact that, and I was, I mean, if he could prove pupillometry didn't work, great, let's not waste our time with this, right? But if pupillometry doesn't work, we know flashlights don't work. So if pupillometry doesn't work and flashlights don't work, then let's stop checking pupils. Quite frankly, if you're not going to check a pupil with a pupillometer, don't check it, because you're not getting reliable information. Okay. Hi from Pittsburgh, Raleigh, Durham, Sao Paulo, Brazil. Hello. San Juan Capistrano, Berlin, Kenya. Wow, lots of great people here. Thank you.
Yeah, we had a lot of great. Germany.
Our TCU folks. Hi, Anna Catherine. Recognize that name. Okay. The streets of Philly. Seattle. Okay. I think unless there's two new messages. Let's see.
A couple. What about non-clinical studies?
Non-clinical studies. Is it viable for neuroptics to mass distribute the devices and do at-home monitoring? Scott, I am not a business person. I would contact them and see. I would think so. The difference between, I guess it's a cost factor. I can't imagine there's not going to be some way that this technology advances. Bill, oh, I recognize the name. Bill Worthen works, he's the president of the company, actually. Thank you for listening in. So, Scott, the answer is yes. I would take him up on that then. But that would be neat to see at-home monitoring just to get the normative data. Misty's ordered pupillometers for all our ICUs. We have one for every bed in our neuro ICU. And in our brand new spine ICU. That's really cool.
I didn't know that was a thing.
It wasn't a thing until Monday. Now, there is such a thing as a spine ICU, and we got it. Dallas is a happening place.
It is.
Hello, Berlin. Thank you. Gosh, it must be late there.
I would think so. They've got to be at least 9 hours ahead of us.
Okay. Hopefully they're watching this. Hopefully Nadine is watching this with a glass of wine or a beer. You're welcome. Thank you. Wine.
8 p.m. with wine. Right on.
Brilliant. Brilliant. 8 p.m. 8 p.m.'s not bad.
No.
Not bad. Okay. Thank you, Kinley. All right. I think we're ending with questions, so I think we can stop the recording at this point.
Alrighty.